Well, we presented several abstracts this week. The ones that come to mind are those that adjust for other cardiovascular risk factors. As you know, the empagliflozin was a SGLT2 inhibitor that was studied in the EMPA REG OUTCOME trial. And this drug was associated with a 14% risk reduction in MACE, as well as a 38% reduction in cardiovascular mortality and a 35% reduction in heart failure hospitalization. These results were quite surprising and really, I think, beginning to change the paradigm of treatment of type 2 diabetes. So we asked the following question: if patients were controlled for their routine cardiovascular risk factors, and we chose blood pressure, LDL cholesterol, and hemoglobin A1C, what would be the influence of that degree of control on the effect of empagliflozin and EMPA-REG? In other words, does control of those cardiovascular risk factors mitigate the effect of the SGLT2 inhibitor? And what we found is that the hazard ratio, both for cardiovascular mortality as well as for heart failure hospitalization, was exactly the same, whether or not patients were controlled for blood pressure alone, LDL cholesterol alone, or hemoglobin A1C alone. We even put them all together, so if we had patients controlled for both blood pressure and LDL cholesterol, as well as hemoglobin A1C, once again, the hazard ratio, in other words, the risk reduction from empagliflozin, was absolutely the same as for the general population. The second poster that we presented dealt a little bit more with this issue of hemoglobin A1C control. And we basically delved into this issue a bit deeper than we could in the other presentations. And here we controlled for hemoglobin A1C, and we found over the course of the trial that there was again, no impact on the hazard ratio reduction. We also looked at hemoglobin A1C at baseline, and once again, when we divided the study group into quartiles, again, no difference. So whether you're controlled or not controlled entering into the trial, you seem to incur a benefit. The other analyses dealt with time periods of hemoglobin A1C. So if we looked at the hemoglobin A1C over the course of the entire trial, and we looked at those patients that had no effect on the hemoglobin A1C at all versus those that had substantial effect, again, no difference, no statistical difference in terms of the risk reduction for cardiovascular mortality. So I think these data suggest that empagliflozin has an additive effect on control of these other cardiovascular risk factors. But more importantly for diabetologists, it does not seem that hemoglobin A1C translates the benefit of this drug. So I think we're entering almost a new world of diabetes treatment, very similar to what the cardiologists have been speaking about for the last few years in terms of statin therapy, that the LDL targeting may not be the actual goal when you're treating patients. It's simply to get them on a statin. And it could be that cardiovascular disease plus type 2 diabetes necessitates treatment with empagliflozin, or we'll see later on today the CANVAS results, perhaps other SGLT2 inhibitors. Well, the presentation that we made this week in terms of the CKD data shows that treatment with empagliflozin basically attenuates the normal progressive decline in renal function that we see in patients with type 2 diabetes at high cardiovascular risk. So when we looked at the first 4 weeks of the trial, we observed a small reduction in the estimated GFR in patients who were randomized to empagliflozin. And that's a normal hemodynamic response to a drug that has glomerular effects as well as leads to some plasma volume contraction. Subsequently, after 4 weeks, however, there was absolutely no change, whereas in the control group, those patients that only got placebo, there was a significant decline in their eGFR. Importantly, after the study drug was stopped and the estimated GFR was checked again, there seemed to be a reversion toward the baseline number in patients on empagliflozin. So this suggests that there is a important protective effect of this SGLT2 inhibitor in patients who have CKD or albuminuria. Well, the future of EMPA, I think a lot of the best response to this question will come later today after we see the CANVAS results. CANVAS is looking at another SGLT2 inhibitor, canagliflozin, and we'll see whether the beneficial cardiovascular and renal effects of empagliflozin can be replicated with that SGLT2 inhibitor. The important questions are whether this is a class effect or something unique to empagliflozin. We don't know that yet. And the second important question is whether these drugs might work in primary prevention. In other words, we had only patients with cardiovascular disease in EMPA REG. In CANVAS, there was a substantial proportion, I think about a third of patients actually did not have overt CVD. They just had risk factors. So we'll see, number one, is CANVAS positive? And number two, what happened to those patients who were described as a primary prevention cohort?